Good morning and welcome to the 2020 Williamson County Caregiver Conference. My name is Rob Fabian with Age of Central Texas, and we are so glad to be hosting this 7th annual Caregiver Conference for you. Now, this is the first year that we have done this virtually, and so if we have a few little hiccups along the way, please forgive us for any technical issues. We're learning as we go, but we are so glad that you're joining us today. We have a tremendous presentation today. And we want to start this morning with a very quick video from our executive director to welcome you to the conference. And then we also have a quick video from our presenting sponsors, Baylor Scott & White Health.
Hi all, my name is Suzanne Anderson. I am the Executive Director of Age of Central Texas. Welcome to the Williamson County Caregiver Conference. We are so very glad that you're with us today. I know that you're not used to attending conferences virtually, so it's sort of a new experience for us all. But I wanted to make sure that you knew that AGE continues to be committed to providing needed information, resources, and support to caregivers, and certainly during this very, very challenging time. So we appreciate your participation and hope you enjoy the day. Thank you again.
At Baylor Scott & White Health, there's nothing more important to us than your well-being. Over the last several weeks, we've done a number of modifications to our emergency rooms so you can continue to get the care you need when you need it. We're regularly cleaning and disinfecting frequently touched surfaces in our lobbies and patient areas. When you arrive, a screener will check your temperature, and we're requiring everyone to wear masks. When it comes to registration, we've got a no-touch process. You just answer a few simple questions. We'll get you back to a room as quickly as possible. We want you to be well informed and not ignore symptoms that could indicate a potentially serious condition. In those situations, it's critical you don't delay. To learn more about all we're doing to help keep you safe, visit bswhealth.com/safecare.
Wonderful. Thank you, Suzanne. Thank you, Baylor Scott & White Health. So a couple of very quick housekeeping issues before we get started this morning. Number one, our session is being recorded. So if for any reason you have any technical issues on your side, if you get knocked off of the call, don't worry. We're going to be posting this session to YouTube, and we'll be doing that later today. And you can go to the Age of Central Texas website for that list, or simply just go to YouTube and search for Age of Central Texas. It'll bring up not only this session, but yesterday's session with Dr. Barry Jacobs, all of those that we did recently for our Striking a Balance conference, and lots of other great things. We'll also be sending you the link for this later on, and we're also going to be sending you the PDFs of the PowerPoint that Michael's going to be using today. So don't feel like you're going to have to take a ton of notes. We're going to send that to you as well. Number two, when you got your reminder email about today's session, we also sent you links about the program and some caregiver resources. So be sure and check out those links. The program has got lots of great information, not only from our sponsors, but also the bios for all of our speakers. And then the caregiver resources, we have pulled together some great resources just for you. And remember, we are doing these conferences for you. So we want to make sure that you have all the resources, all the information, all the knowledge that you need to help you be successful in your caregiving journey. Finally, there's a chat feature here on Zoom. It's right down here on your window. It looks like one of those dialogue bubbles from the comic strips. Click on that, and it's going to bring up the chat box on the side. We want you to ask questions during Michael's presentation, because at the end of the presentation, we're going to answer your questions. As again, this is for you. We want to make sure that we're giving you all the information that we can, and this is your opportunity to ask one of the leading experts in the region your questions about long-term care communities and what's going on with COVID. So be sure and ask those questions. Now, because we do have a little bit of limited time today, if we get a lot of questions and we're running long on our time, we may not be able to answer every single question live today. However, we will answer your questions. If we run out of time, know that someone from Aegis Central Texas is going to contact you directly and answer your questions. So please ask those questions, because again, this is your opportunity. We wanted to present this for you so that you can find all the information that you need, talk to the experts, and learn as much as you can to help you in your journey. At the end of our presentations this week, we're also going to send you a survey. And we'd love for you to fill that out for us, because we read every single survey from the sessions, and it helps us for next year. So you tell us what you need in your journey as a caregiver, and we will go find the experts to give you that information. All right. So again, we thank you so much for joining us this morning. And we also are very grateful to have Michael Gill with us. Michael is the president of Senior Living Locators, which is a regional company here in Central Texas. He works with families to help them find the best senior living housing options here in Central Texas. Michael is widely considered one of the leading regional experts in senior living options. And we've had him speak at other conferences that we've done. He is just the expert when it comes to the senior living locations. He was also a caregiver for his mother, and so he comes at it from both sides, both being the professional expert who knows so much about the area, but having been a caregiver himself, he understands what's happening in your world. He's also a certified senior advisor, and his corporate background includes banking and finance, and he has worked everything from venture capital to having worked on Wall Street. He has co-authored 2 books on finance, and he's also a certified fraud examiner. So, Michael, thank you so very much for joining us today. We are so excited for your presentation, and I'm going to turn it over to you.
Thanks, Rob. I appreciate that very much. Rob says that I am an expert in senior living. What I do is I help people find assisted living, independent living, and memory care. It's called a senior locating service. As such, over the last 6 months of the pandemic, I've been helping people find these type of places still. And so I have been in contact with each of the different communities, trying to figure out which one is still most appropriate for my different clients. Because I've been in contact with these people, I know pretty much what's been going on every place around the community in terms of how people are dealing with COVID. So that's where my expertise comes from. Let me start out. We do have a PowerPoint presentation to help you follow along. So I'm going to go ahead and share that now. Hold on while we get the technology working. Okay, and Rob, all I see is Williamson County Caregiver Conference. I don't, which is your screen, I believe, not mine. Can you see my screen okay?
Yes, I've got your screen showing, so you're good.
Perfect, okay. Sorry, everybody, for that technological glitch. There's always glitches when we're doing Zoom and on this new technology. At any rate, what I'm going to be talking about today is senior living as I define it. Now, most seniors live at home. Over 90% of people live at home and end up passing away at home. But there's a large, over 10% of people end up going to senior living. So let me just give you some quick definitions about what we're talking about. I'm going to talk about 5 levels of senior living, and I'm going to describe them in order of decreasing acuity, meaning generally the one at the top has the highest level of care. Skilled nursing homes is a place where is predominantly paid for by Medicaid and Medicare. There are 3 different types of people that go to skilled nursing homes. Number 1 is Medicaid clients. A typical nursing home, over 50% of the residents there are going to be on Medicaid. Another 20% of the clients at a nursing home are going to be there for short-term stays, usually 3 or 4 weeks, where they're getting rehab after coming out of the hospital. Usually, after somebody has a urinary tract infection or a stroke or breaks a hip, they go to get rehab, and that's paid for by Medicare. And then the third clientele that is in a skilled nursing home are private pay clients. And that's about 30% of the clients there at a nursing home. Memory care is all private pay, and memory care and assisted living, they both share an assisted living license in Texas. Memory care has an additional certification so that it has a lock on the front door. Everybody has to have a dementia diagnosis to be allowed in because of the lock. Obviously, they don't want to lock somebody up who's not appropriate there. And then the third thing is that memory care has more caregivers in its per resident than they do in assisted living. Assisted living is the third type of level of senior living that I'm going to talk about. That's where people receive help with activities of daily living. So we go there to get help with dressing, bathing, eating, meaning getting it from your plate to your mouth, not preparation. But dressing, bathing, eating, transferring, meaning getting out of your chair and into a wheelchair or to your walker. And so some people have a hard time transferring, for example, off of a bed where there's no place to push off of an armchair. And so people need help transferring, just getting up and moving about. Toileting. Toileting is where somebody needs to go to the bathroom. They know they need to go, but they may have an accident on the way to the toilet, or they may not be able to pull their pants up and down, or they may not be able to do all the other things you need to do in the toilet, and so they need help with toileting. And that's different from the sixth activity of daily living, incontinence. Incontinence is where all of a sudden you're wet and you didn't know you needed to go. That's fairly typical with people in memory care, but it happens in assisted living as well. The seventh activity of the daily living, which is not an official activity of daily living from the perspective of long-term care insurance or veterans benefits, is medication management. So assisted living and memory care is different from skilled nursing in the sense that, number one, they're private pay, and so Medicare and Medicaid pays for nothing there. And number two, skilled nursing home is where you need nurses around the clock for things like IV drips, ventilators, feeding tubes, tracheotomies, etc., or you need the government to be paying for it. So that's the difference between a skilled nursing and then assisted living / memory care. The next level down in the senior living community that we're going to talk about is independent living. Independent living are apartments surrounding a centralized dining room with a meal plan, but they are not regulated by any agency. That's because they're not a healthcare oriented place to live. So they're basically just an apartment building. However, they do have a lot of outside caregivers coming in to the building frequently. They usually will have an office where there is an outside caregiving agency, and so they can do help with activities of daily living from a different payer source than the building. But one of the most important things that we'll talk about this more, is the fact that they're not a regulated entity. And finally, there's 55 plus communities. We won't go into those too much, but those are basically apartment buildings that restrict the people who can live there to being 55 and older. That's sort of a newer segment in the market. We go down to the next slide and just talk about what the problems we have going on. Obviously, we know what the problem is. The problem is COVID. And with COVID, that's why we're doing these Zoom calls instead of an in-person presentation. COVID is a particular problem for people over 65 years old. That's because the chances of dying if you're over 65 rise dramatically as compared to if you're much younger. There's been a lot of numbers thrown around, but generally the numbers that I've seen is that you have about a 2.5% chance of dying if you're over 65 and come down with COVID. If you're over 80, it could be as much as 20% chance of dying. So obviously, we're trying to keep COVID out of all the senior living buildings, and it's quite important for that reason. Now, the senior living buildings, the people are uniquely vulnerable, not only because they're age, but also because it's congregate living. So in a nursing home where we've had the highest levels of death and the biggest problems, one of the problems is it's a medical model as compared to a social model. And so you have caregivers going from room to room sequentially one after another, helping people change, they're going to the bathroom, change their diapers. They may have to be picked up and moved to prevent bed sores or something. these are people that are, quite far along in their journey. And as such, the caregivers are going from person to person to person. Now, even during COVID, even before COVID, you're supposed to be washing your hands. You're supposed to be, gowned, wearing gloves. But before COVID, we didn't have masks and we didn't have full personal protective equipment, i.e., PPE. But now with COVID, we're trying to do that a lot more. In the early stages of COVID, though, it was a particularly big problem because a caregiver would be going from room to room, from client to client, resident to resident, and then on the night shift, a different caregiver would be doing that. So if a resident came down with COVID, then there was a good chance that a caregiver would come down with COVID. And then that caregiver could transfer it to other rooms, and those other residents could transfer it to other caregivers. So particularly in the early stages, when we weren't as good at having even PPE, et cetera, there was a lot more transmission of the disease. The skilled nursing homes are set up in a congregate living way that they've had the biggest problems. And we'll get into that in just a second. Anyway, my point is that congregate living, obviously you have people going from room to room. There's much more spreading available, spreading opportunities, transmission opportunities than there would be, say, at home. And the last thing I just want to mention about the problems with COVID is that the regulations are inconsistent. So when we're talking about a skilled nursing home, skilled nursing homes are regulated by the Centers for Medicaid Services, whereas assisted living, and that's a federal regulation, by the way, whereas assisted living and memory care are regulated by state agencies, currently the Housing and Human Services Department. And independent living 55 plus are not regulated at all. There are regulations that have been promulgated by the local health authorities, though, that do end up impacting independent living, such as the fact that you can't have more than 10 people getting together when we're in stage 3 or stage 4 of COVID protections. And that's been mandated by the local public health officials. And so independent living does have to comply with those type of regulations. But the inconsistency of the regulations is part of why I'm giving this presentation today, because we have to discuss all the different levels of care and who's doing what in which part of the industry. So we can pretty much understand how people are going to, or how all levels of senior living are going to try and respond to the COVID crisis. There's basically 3 strategies. Number 1, let's keep it out of the building if we can. Number 2, if it comes in the building, how do we figure out how to minimize it, how to contain it, to not have it spread among all of our staff and residents. And number 3, once we've passed it, we have to figure out how to safely reopen, because we can't stay locked down forever in the tightest of circumstances. So this is what we're going to be talking about for the next 3 slides. So number 1, let's talk about what it means to keep it out. What are our range of options? Well, first off, we're going to try and, every place is going to try and minimize the traffic into the community. So as we all know, any of us who have loved ones in senior living, families are the first people to have been basically asked not to come visit their loved ones. And there's a good reason for this. So we want to minimize the potential threat vectors. If you're an assisted living, for example, and you have 100 residents, you're probably going to end up having 60 staff members. But if you have 60 staff members, you're also going to have, say, every person living there is going to have some family member, or maybe 3 or 4 family members who want to come visit. So you go from 60 people visiting the community to 260, for example, if every resident had 2 family members. And then there's also other outside vendors who come into the building. So there's home health, there are doctors' services, there's podiatrists, there are lots of other services. And so every time the more people you can keep out of the building, the more you can limit the transmission of COVID. So that's one thing, is to try and keep it out of the building. Second thing that they're doing is they're trying to limit interaction as much as possible. So for example, most places for the first several months, 4 or 5 months of the pandemic, they weren't allowing people out of their rooms, or they were strongly encouraging them to stay in their rooms. And then if they did come out of their room, they're all supposed to be wearing masks. And to keep people from coming out of the room, instead of having people congregate in the dining rooms, they are delivering meals to the rooms instead. And they either canceled activities or they limited activities at first to no more than 6 to 10 people, depending on where you are. So you're trying to limit the interaction between the residents and between staff as much as possible. Third thing you're trying to do is limit incoming infection vectors. By this, we mean families would often drop off homemade food for their loved ones, or they would take their laundry home and they would do the laundry for their loved ones, because this is one of the intimate things that we do for our families. Well, all those things have been eliminated. For example, and we'll talk about this some more, but some nursing homes are not allowing you to drop off diapers for your loved one unless they are in closed bags that have never been opened, because they're trying to make sure that there's no way for the infection to come in the building. Similarly, what they're doing is if you get an Amazon package delivered, they're holding that for 48 hours before they give it to you, to try and give any potential pathogens a chance to die before it's brought into the building. Next thing that they're doing is they're making sure to screen all the staff that come into the building. When the pandemic started, we started by just taking everybody's temperature. Later on, we started asking all sorts of questions to try and filter people from, that may have had some sort of exposure to COVID. Initially, we were asking people whether or not they'd just come back from Italy. Of course, it's the other way around now. Nobody wants anybody from Texas, because we had a large spike in early July, so it's kind of silly to be asking people if they just come back from Italy when nobody's going to allow us out of the state practically. I mean, I think we're still not allowed to go to New York, for example, without a quarantine. So now there's lots of questions that go on. Have you had fever? Have you had a cough? Can you still smell? These are the type of things that they're trying to do in addition to taking people's temperature. They're increasing sanitation measures. So as you saw in that Baylor Scott and White video earlier, they're trying to sanitize high-touch areas like doorknobs and railings and the countertops of the nurse's station, et cetera. So they're trying to limit those type of threat vectors. And of course, they're screening residents daily. And by that, I mean, they're not only taking their temperature, usually twice a day, depending, but they're also asking, monitoring if anybody's got a cough, if they're sneezing, everybody turns around. So they're, everybody's being hyper vigilant about any potential symptoms that could be related to COVID. And the last thing is, as I said, there are restrictions for vendors. So sometimes when vendors absolutely have to come into the community, they're only allowed to go straight to a certain person's room. They're not allowed to go by the dining room if there are people there. And they're also trying to make sure that everybody does as many video calls as they can as compared to in-person visits. So doctors are doing an awful lot more telemedicine these days than they ever used to. So that's how they're trying to keep it out of the communities. Let's talk next to the next painted if the coronavirus does get into one of these senior living communities. So first thing is, right now, they're allowing some people into the building. They're trying to minimize it, but doctors are allowed in the building. They need to see their residents. If coronavirus does come in the building, well, even doctors, except in emergency situations, are going to be asked to stay out of the building, only do Zoom calls. So they're going to even further restrict any visitors. In some cases, admissions people who aren't considered essential caregivers aren't allowed in the building, for example. So you further restrict traffic into the community. Then you further restrict interaction. So whereas people were encouraged to stay in their rooms before, they may now be mandated to stay in their rooms, not allowed to leave the rooms if there is infection in the community. Obviously, they're further controlling infection vectors. They may not be allowing any packages into the building, for example, and et cetera. They're still screening staff, but if there's coronavirus in the building, staff have gone from wearing masks to wearing masks and gloves and full PPE and probably also face masks. So they're being much more strict when there's coronavirus in the building. Also, most buildings are supposed to have a plan for quarantining their residents. So some buildings will be told, okay, let's take the end of that hallway and move people out and keep the end of the hallway where we have all of the coronavirus sufferers for right now, et cetera. And obviously no coronavirus positive staff members can be allowed in the building. And then they also have to stay home for 14 days and get testing, et cetera. And so when you do get coronavirus in the building, usually one of the first things they do is they try and test everybody. Now, the problem with testing everybody is it's often taken 4 or 5 days to get the test results back. And so even in the meantime, they go ahead and they shut the building down as much as they can. And they also start contact tracing. So fortunately, in most of the cases where we've had coronavirus in the building, it's usually been one or two people who end up getting it. They figure out, okay, there's a staff member who went ahead and stayed home today. They're not feeling well. Who has that staff member been working with over the last 3 or 4 days? And then they start looking at the residents and other staff members with whom that person has interacted, and they're doing the contact tracing, and they're increasing the vigilance, watching those people to much higher levels to try and catch the coronavirus there, and so that they're not transmitting it to still more people. So that's the main idea of how they're trying to contain it once coronavirus does get into a building. The next question comes down to, okay, we've had coronavirus in the building. How do we safely reopen? And when is it safe to reopen? Now, everybody does this a little bit differently, but let's just talk about a few things. If a resident has gone out of the building because they went to the hospital, then they generally they have rules for the returning residents, such as they have to have had at least 2 negative COVID tests, and then when they come back in the building, frequently they still make them quarantine for another 14 days afterwards, even though they've had 2 negative tests. For returning staff, a lot of it has evolved. And the reason that it's evolved is because early in the pandemic, we didn't have enough testing for everybody. And so it was really hard to test a whole community until probably 2 or 3 months into the pandemic. And so early on, what they were doing with staff members, because A, it was expensive to go ahead and test everybody, and B, they couldn't get the tests for everybody. So what they would do is a staff member who tested positive would have to stay home for at least 10 days after the onset of symptoms and at least 3 days after the symptoms went away. So if you came down, say, on the first of the month COVID, you would have to stay away from the building for at least 10 days. But if you still had a fever, 10 days later, you'd have to wait till at least 3 days after the fever went away. So they were doing that because most of the CDC guidelines and everything said that people were not contagious beyond a certain period. So people were usually contagious, 3 days after being exposed to, say, 10 days after being able to be tested. And so most of the time, if you couldn't get tested, you'd go ahead and say, okay, after that period is when it's safe to come on back. So there's rules for returning vendors too. Typically, once a building is declared COVID-free, they wait about 14 days to allow anybody else in the building. So returning home health aides, returning hospice aides, people like that aren't allowed in the building until there's been at least 14 days that have passed. And then there's the question of when can you admit new residents, and that's a similar type of rule, which is you can't have any new residents until 14 days, until you've been clean in the building for at least 14 days. So trying to reopen safely, it's not always consistent. And so one thing that we kind of have to recognize here too is when you're asking questions about, how are things going, the answer is usually it depends, because there are no clean answers for a lot of things. We still don't know whether or not you can get COVID a second time. We don't know how long the infection period completely is. So we're doing things, a lot of things out of an abundance of caution, so to speak. And a lot of that abundance of caution seems silly and may indeed be silly, but everybody's a little bit scared by this. So, we're going to extreme measures, which makes sense. So now that I've talked about the general sense of how we're doing, trying to deal with COVID, which is, keep it out, contain it, and safely reopen, I'm going to go over every different level of care in skilled nursing, et cetera. So skilled nursing. First off, skilled nursing was the hardest hit category of senior living. In some countries, skilled nursing had over 70% of the number of deaths any place in the country. For example, in Quebec, Canada, they had 71% of the deaths happen in nursing homes. In Europe, it's over 50% of the deaths that would happen in nursing homes. In the United States, it's been about 40% of the deaths. And we have to say about because there's a lot of definitional issues here. If somebody was already dying of heart disease and it turned out that they were also infected with COVID, did they die of COVID or did they die of heart disease? So there's a lot of, the numbers aren't always all that good. In Texas, the numbers that we have for skilled nursing is that there were over 26,000 cases in skilled nursing homes and over 3,700 deaths. And over 80% of all skilled nursing homes had at least one case of COVID. So skilled nursing has been a pretty bad place to be in times of COVID. So what did skilled nursing do? Skilled nursing had the most strict lockdown measures of any level of care, as you would expect. And also, let me just mention, in Austin, there were about 5 different skilled nursings that had particularly bad experiences with COVID. And these are places where there were, say, over 50 different cases within the building. So there might have been, say, 30 cases among residents and maybe 20 cases among staff. And in some cases, I think the nursing home that had the most deaths had over 22 deaths. That was a very early outbreak that happened in April. Unfortunately, there have been outbreaks where there were 80 cases in another nursing home that happened as recently as July. Now, one of the problems that we've been having in terms of nursing homes is we haven't been able to find out who's got cases. Early on in the pandemic, one of the things that everybody was worried about was the fact that hospitals were going to be overwhelmed. So hospitals were, what they were doing is they were stabilizing their client or patient, and as long as the patient wasn't in any further danger, they would send them to a nursing home on the theory that, hey, nursing homes deal with influenza every year, and they've got infection control measures, so they should be able to deal with a COVID positive resident, as long as they're not in danger of dying or something. Well, one of the problems with that, of course, is that infected the rest of the community in a lot of cases. That was particularly true up in New York, for example. And it took about 2 months before they finally decided, and this was a political decision among the governors and things like that, where they said, okay, we're not going to send residents back to the nursing homes. And by the way, the nursing homes were not allowed to refuse taking in the COVID positive residents at that time. Since then, that has changed. But obviously that was a big problem, and a lot of people died because of that mistake. And by the way, it's not only in the United States that happened. My wife's family's from Belgium, and in Belgium, it was effectively illegal to send somebody from a nursing home to a hospital if they had COVID. And the reason for that is, particularly in Italy, at the early stages of the pandemic, they were sort of the case study. And what was going on was they had limitations on how much hospital space they had in northern Italy. And so they were just not treating anybody over 80 at that point. So there was a huge death rate going on in a lot of Europe. And so places like Belgium went ahead and said, oh, okay, we're not going to even allow seniors in the building. We're going to run out of space for them. Well, they never ran out of space. They never got that full, but it was a huge mistake. And there's been some scandals because of it, and certain ministers across the world have lost jobs because of the way these things have been handled. At any rate, that's a very negative view on what's been happening in nursing homes. But as you know, if 40% even in the United States, people who are dying of COVID are dying in nursing homes, it's something people need to be aware of. So nursing homes are the strictest places from the perspective of locking people down. They're prohibiting all non-essential visitors. The only exception is end of life. So people are generally allowed in the building when somebody is dying, the families are, for the last week or two to see their loved ones. And that didn't happen until a month or two into the pandemic, by the way. Initially, they weren't allowing anybody in. So as I said, they prohibited delivery of non-prepackaged items. So you can't drop off lasagna for your loved one. You can't even drop off a bag of, or a box of granola bars unless the box is sealed and hasn't been opened. And they're, as I said, they're making people wait 2 days before they get their packages, etc. New residents in these places are all required to be quarantined for 14 days. Staff members are checked rigorously upon entry and exit of the building. All staff members are having to wear gloves, masks, if there's no COVID in the building. And as I said, if there is COVID in the building, they have to wear gowns and face masks as well. When people, there's an awful lot of dementia that goes on in the skilled nursing homes. So they do say everybody has to wear masks except for those who can't tolerate them. And of course, a lot of dementia clients and residents, they don't know why they have to wear them and they take them off and you just can't keep them on, but they do their best. And what they generally do too is they will set up an isolation area for new residents, for exposed residents, and for COVID positive residents. Of course, trying to keep the COVID positive residents restricted from everybody else, but they're trying to go ahead and quarantine it in one part of the building. So that's skilled nursing. Also, I will mention that early on, it was thought that they could take 1 or 2 skilled nursings and make those the place where they would send all COVID positive residents. Well, because all the skilled nursings are privately owned, et cetera, that didn't really work. There's one skilled nursing in town that did take half of its facility, and it had an architecture such that they could, they could eliminate half the building and wall it off from the other half of the building. And this is Hearthstone up by Round Rock Hospital, and they had 60 beds, and so that's one place that was a receiving facility for people who were positively identified with COVID. Most other skilled nursings, they would keep their COVID positive residents if they got them in the building, but they pretty much weren't able to send them out anyplace else. However, and this is the next slide is we're going to talk about, is the assisted living and memory care. In assisted living, when an assisted living would get a COVID positive resident, they were able to, they would usually try and send that person out to the hospital and then not readmit him until they were COVID free. And the receiving place for that type of resident was Hearthstone. Early on in the pandemic, some of the long-term acute care hospitals, which would be, say, Cornerstone or Texas Neuro Rehab or Warm Springs, some of these places were taking residents, but they tried not to take COVID positive residents if they could avoid it, and they tried to concentrate it as much as they could. But Hearthstone at one point, for example, in the pandemic had, was full with 60 residents that with COVID-19 and had a waiting list of another 15 people or something. So it was difficult for assisted livings when they tried to send residents out and find room for them, even for residents who weren't particularly sick but were COVID positive. Anyway, assisted living and memory care. Generally, the memory cares have been more stringent than the assisted living, but they both generally follow the same style. So they prohibit all non-essential visitors except for end of life. So no family members, all doctors and nurses and hospice people are trying to do telemedicine. Home health is usually allowed in the building, but what some people did, for example, most buildings have 3 or 4 or 5 different home health companies servicing clients within the building, because because home health is every patient has the right to choose whichever home health company they want. But what some of buildings would do is they go ahead and say, okay, we're only going to allow one home health company in the building, and all of their physical therapists or occupational therapists, they can only work in this building. So they're not allowed to work in another building because we don't want them bringing in somebody else's infections. And because we're giving them all of our business, that should be enough business that they shouldn't have to go to other buildings. So that's one thing they've been doing in terms of trying to limit non-essential visitors and try and keep as many people out who are potential threat vectors. So new residents are always required to be quarantined for 14 days. There are some places that have changed that, where if you have a negative COVID test, within 7 days of moving into the building, and then a second negative COVID test within the first couple of days of moving into the building, then they'll let you out of that 14-day quarantine much quicker. This can be a problem in memory care, because memory care people can't always be kept in their rooms for 14 days because they don't understand what's going on. So there are some memory care places that have been requiring around the clock 24/7 personal caregivers for the first 14 days in order to keep people isolated and not allow COVID in the buildings. There are other memory cares that are allowing people out of their rooms immediately as long as they haven't had any temperature, and as long as they haven't been going out to parties and restaurants and stuff before coming in the building. All residents who are able to tolerate residents are encouraged to wear masks. Residents are encouraged to isolate their rooms. Generally, in assisted livings, they have not been using the dining room for the past 6 months. Within the last month or so, some assisted livings have been opening up their dining rooms. But most of the time, even today, I would say 75% or more of places are not doing meals in the dining rooms, and probably over 90% of assisted living residents and memory care residents are still eating in their rooms. Visitation policies have been changing. Initially, there were no visitation policies, no visitations allowed, period. Now, then window visits became acceptable. Most places have a window visit policy where there may be an exit door that has a window, and so they go ahead and they're allowing visits through the window. As of about August 13th, the governor has said that we're allowed to start having visits from families. So there's two ways that this is happening. Number one, you can do visits outside, and then they go ahead and usually put a piece of tape on the floor and designate 6 feet apart, and they have a chair over here and a chair over here, and you're not allowed to be any closer than that. Nobody is allowed to hug. Then inside the building, what they've been doing is typically they've been taking the formal dining room, or the family dining room, where you can have up to, say, 6 people sitting at a table for special events like birthday parties. Well, they've been taking those family dining rooms and they put a large piece of plexiglass right in the middle, and they put the resident at one end and the family can come in the other end, but they're not allowed to hug. And so what they're doing is they're allowing those type of visits, say, once or twice a week, and it has to be scheduled. So that's getting better. Probably only about 20 or 30% of assisted livings so far have been allowed to do visitations. And when I say allowed, what I mean by that is that the assisted livings have to apply to the state, have to show where they're going to have the visits, show their plexiglass, and show their outside area, and then the state has to approve it before it happens. Going back up for a second to skilled nursing, there's between 12 and 1,300 skilled nursings in Texas. So far, visitation has only been allowed in less than 30 of them. So they're starting to allow visitation in skilled nursings as well, but the restrictions are so severe that so far it's practically not happening. In assisted living, though, it's, as I say, probably 20% of the places have started to have visits other than window visits. and that should be increasing going forward. Now, let me also mention, there's another category of assisted living that it's technically still an assisted living, but it's a little bit different. They call them personal care homes. These are small homes where there's potential of 6 to 10 residents in a house. Usually these are single family detached residences where they have gone ahead and say enclosed the garage or the formal dining room or the formal living room and made extra bedrooms. And then they've gone ahead and done some renovation on the bathrooms so that they're more wheelchair friendly. And they've turned these into small assisted livings. So they are actually licensed most of the time. And so these personal care homes are a little bit different in that they've been more liberal about allowing visits. Some of them will allow visits out on the patio. Some of them will actually allow people to come into the straight from the front door to a person's bedroom, and they can visit while they're in the bedroom as long as there's no more than 2 visitors. So there is a lot of disparity between how people are doing things, and the personal care homes have generally been a little bit more liberal about allowing visitation. Moving on, let's talk about independent living. Now, I mentioned earlier that independent living is unregulated. Independent living is not a healthcare. The building of independent living is not allowed to hire caregivers, and so they're not regulated as a healthcare entity. So the rules there are much more inconsistent, and it all depends on what's going on in that building. And by that I mean, number one, there is the personality of the corporation. Some corporations have been very cautious. For example, Atria, which is on Great Hills Trail near the Arboretum, their lockdown was as strict as any place, as any assisted living or memory care. And if anybody left the building, they to go to a doctor's appointment initially, at least, they were required to quarantine for 14 days, even just for visiting the doctor. That's since been relaxed somewhat, but there's just, as an independent living building, they're not allowing families to visit their loved ones in the building. On the other extreme, there are certain buildings where residents can come and go from the building with nothing more than a temperature check, and where families can come and visit no more than 1 person at a time, typically, or 2 people at a time, but they can visit their loved one in their apartment with nothing more than a temperature check, as I say, and a list of questions. Meaning, have you been exposed? Have you been out of the country? Have you felt sick or had a fever in the last 14 days? That type of thing. So very inconsistent because of the lack of regulation. Most of the time in independent living buildings, though, meals have been delivered. And that's because the local public health authorities have said you can't have more than 10 people in a room. So even today, I would say 75% of the independent livings are exclusively delivering meals. Now, some of the independent living some independent living communities have started food service in their dining rooms. But because you can't have too many people in the dining room at once, what they're doing is they are, they're limiting 2 people to a table. They are spreading the tables out much further, so the capacity is much lower. So you might only be able to get 40 or 50 people in a dining room that's designed to hold 150 people. So because you can't have everybody come to the dining room at the same time, what they've been doing is they've been stretching out the hours. So you may have the first seating from 11 to 12 and the second seating from 12 to 1. Or they may be going ahead and say, the South Wing can eat meals Monday, Wednesday, and Friday, and the North Wing can do Tuesday, Thursday, Saturday. So they've been trying to come up with creative ways to get people back together because isolation has been terrible. They've been increasing number of activities, and because again, they've been doing activities outside. They now can have 10 people doing activities instead of 6 people doing activities, which is a little bit better. And so, and residents are requested to be in their apartments if possible. But the only time they're required to isolate in their apartment is when they get COVID-19. And when they get COVID-19, things do change. However, I'll give you an example. There's another independent living where I was allowed to go take somebody on a physical tour. And I wasn't told at the time, but they actually had an active COVID case in the building, which really upset me because they didn't tell me about it and didn't give me the option to say, no, I don't want to come to the building. But at any rate, this is how inconsistent it is in independent living. I'm not going to say much about 55 plus communities. Generally, 55 plus are just apartment buildings. All staff are required to have temperature checks and wear masks. Residents are encouraged to wear masks, but they're not doing as many activities. And obviously, any COVID positive resident is told that's the only thing they can tell them is that you have to stay in your apartment if you're COVID positive, and please get help because we can't come in and help you. So since the initial lockdown, things have gotten a little bit less restrictive. So limitation, I've talked about a little bit that there is limited visitation that is beginning, and it has been consistent. There's been a lot of visitation in some independent living communities. There's been zero visitation in assisted living and memory care until mid-August, and that's slowly opening back up, but that's opening up faster than it is in skilled nursing. The isolation requirements are relaxed, so residents are now able to go out to doctor's visits and come back in without doing a 14-day quarantine, though they are requested not to go to a restaurant or to Walmart on the way back or something. As I say, some community meals have resumed, some activities have gotten bigger. Now, during the initial lockdown, one of the things that would happen is that for people who wanted to move in the building, they weren't allowed to visit the building. So what does happen? Let's talk just for a second about tours for new admissions that have been happening. So even up to today, 95% of the tours I've been doing since March have been done over Zoom or over FaceTime. And so what we end up doing is we have a sit down in the admission person's office. We end up doing the discovery where we talk about the potential resident and what their care needs are, whether they need help showering or with medication management, et cetera. And then the admissions person will take their iPhone or their laptop, and they will walk around the building showing the various different parts of the building to prospective residents. And that will probably continue to be the predominant way that we do tours for the next, until the pandemic is over. However, there are an occasional assisted living or memory care that has said, well, because people are moving to a higher level of care, new visits are acceptable because these are considered essential visits. That's the very rare exception. So most everything is going over Zoom. Then also when people move in, there's a question because in assisted living and memory care, most of the time, 95% of the time, people have to go ahead and decorate their own apartments. So you have to bring in some chest of drawers and a bed and a recliner and a TV. Well, before the pandemic, obviously the family would go ahead and feather their parents' nest for them. Now, most of what's going on is assisted livings or memory cares are requiring people to hire either a certain mover, or they're requiring the family to drop off all the equipment or all the furniture in the morning, and they leave it outside, so long as it's not raining, of course. They leave it outside for the day to hopefully disinfect, and then the staff of the assisted living and memory care will carry it back to their room. An occasional assisted living or memory care is allowing family, one member of the family to come in to decorate for no more than 2 hours, in full PPE, of course. That's again the exception. That's probably only about 20% of the places are allowing family to come in to help at all with decorating the rooms. So the move-in procedures are also quite limited. So one of the questions is, how long will we be, in this lockdown? And my answer is we're less than halfway through. We've been in the lockdown since mid-March. It's mid-September. That's 6 months. I expect early spring is the earliest we're going to be able to get back into the buildings. So let's just go over the questions of when we're going to be able to get back in. Number one, we're going to have achieved herd immunity, and the only way to achieve herd immunity is to get vaccines to everybody in the country. So from what we're reading in the papers, there could be a vaccine by, election day. That seems unlikely. So let's assume just, beginning next year is what people are saying. So assume that we have a vaccine on January 15th, 2001. Well, the two primary vaccines, Moderna and Pfizer, I think it is, those vaccines are going to require a booster shot. So you get one shot, and then a month later, you're supposed to get a second shot. And then 2 weeks after the second shot is when you're going to have full immunity. So the first shots will be given, say, January 15th. The first people to have the immunity would be starting March 1st. Now, who's going to get the shots first and when? Because we're not going to have all the shots available immediately. So presumably, first responders and people in the hospital are going to be the first people to get shots. I don't know when skilled nursings and assisted livings are going to be given priority. Given the high death rate, I would hope that skilled nursings would be given a very high level of priority, but we will see. Next thing is, it doesn't seem like we've done much to figure things out as to how vaccines are going to be given, because you have to document who's getting vaccines and when, and then you have to follow up, because if there's an adverse reaction, you want to make sure that we're seeing what's going on. I don't know how many people remember the swine flu vaccinations from 1976, but there was a lot of adverse reactions, and so they stopped giving the vaccines at one point, and that's going to happen with all our vaccines today as well. The next thing to remember is that, by the way, we don't know that a vaccine will be available on January 15th. We saw, for example, that the trial over in England was stopped for about 5 days when somebody got transverse myelitis. Transverse myelitis is a certain type of inflammation in the spine. Now, they had to figure out, okay, was that reaction caused by the vaccine, or is that just a random reaction? Because when you've got 30,000 people taking a test, there's going to be some funny things going on just because 30,000 people are going to have something going on, whether it's a sexually transmitted disease or some strange encephalitis or something. At any rate, they shut down the test for 5 days to try and figure out if this was related to the vaccine. They've opened it back up again. They're going forward. So, we could very well have other problems with any of the vaccines that are currently under production, and it's going to be, it's a crapshoot as to when vaccines are going to be available, because there's a lot more water that has to flow under the bridge before we get to the point that we know that a vaccine is going to be available. We have vaccines today. The question is, what's the risk? What risk are we willing to assume with the vaccines, and what's an acceptable level of risk? So if one person out of 1 million gets a side effect, that's probably acceptable. But if it's 1 out of 1,000, that's probably unacceptable. And that's just something we're going to have to wait and see what happens. Now, the mechanics of a flu shot are going to be a problem, because we can't all go to the local high school gym and line up and wait for our shots. I don't know about the rest of you, but I remember as a child, about 7 years old, going to the local school and getting my sugar cube with the polio vaccine. Well, we were able to just walk on in, take a sugar cube, and walk back out. We're not going to be able to do that, because this is an aerosol transmitted disease. So we're going to have people 6 feet apart. There's going to be long lines. Don't know how they're going to go ahead and do flu shots or these COVID shots. And one of the other problems is that the current 2 vaccines that are furthest along, Pfizer and AstraZeneca, Pfizer, I think, is the one that all the vaccines have to be stored at 4 degrees below 0 Fahrenheit, whereas the other vaccine has to be stored at 90 degrees below 0 Fahrenheit. So the cold chain has to be put in place. So it's going to be a while before we figure out how that's going to happen. Now, the other thing is, okay, who's going to give all the shots? Well, if we have medical students or we have people who aren't nurses giving shots, we're going to have it's state health regulations that determine who can get the shots. So we have to work through that. Point is, there's going to be surprises, there's going to be mistakes, there's going to be some abuses, there's going to be violations, where people say they got the vaccine, but they really didn't. And what do we do with the anti-vax crowd? What if we have a bunch of people in any given assisted living who say that they don't want their parent to get the vaccination? That's going to make things difficult too. My only point is the vaccine is going to take a while, and we don't know exactly when. My guess is that it's probably going to be April 1st is the earliest we could open up some of these places, because we've had everybody in the community get shots, and it could easily be sometime next summer. So we're talking 8 months away from today for shots, and we've only been in the pandemic 6 months. We're halfway there. Now, a lot of people call me and say, I'm just waiting to move my parent until the all clear happens. Well, what does all clear look like? All clear is going to be what it was like in February of this year, where families can come from the building without having their temperature taken, where residents can come and go without having that restriction, or whichever vendor we want come in, where we have full meals and activities, and incoming residents for the community, where we don't have to think, well, when is the all clear happen? As I say, the best case of a vaccine is going to be January 2021. There's going to be required 650 million doses, because everybody's going to need to have 2 doses. I think full vaccine is going to take 4 to 6 months. So probably sometime next summer is when things are going to start to feel like they're returning to normal. And if we have any problems with vaccines, or there's unexpected reactions, and we have to go to a different vaccine, this pandemic could continue to go on through the end of 2021. I don't think that's going to happen. I'm praying it doesn't happen, but I don't know. So the last thing I want to leave you with is, okay, when is the right time to move my loved one to assisted living, memory care, or skilled nursing? Well, the answer comes back down to one question, which is safety. I've got 3 rules when you need to move. Number 1, if your family member is not safe at home, then they need to move. By this, I mean, if they're not taking their medications properly. So a lot of people who are coming down with dementia may take their medications 4 or 5 times in a row, forgetting that they've already taken that morning, and they end up in the hospital with overdosed on their pressure medication. This is a common thing I see frequently. Or they leave the stove on, or the bathtub running, or they wander outside and can't find their way back to their house, or their etc. Those people have to move. The second reason people have to move is if they'd be healthier elsewhere. Usually this is an individual, not a couple, but an individual who's doing a lot of self-neglect. They're not feeding themselves properly, they're not taking their medications, period, or they only remember them occasionally. Or they're isolating and only watching TV, and they're going downhill because they're isolating. They'd be healthier someplace else. They need to move. Third reason somebody needs to move is when there's caregiver issues. By that I mean if you're living out in a rural area and the caregiver calls in sick and you can't get a backup caregiver, or if there's an 85-year-old woman who's taking care of a 90-year-old husband who's got dementia, and that 85-year-old woman has her own health problem, no longer to take care of her husband. These are times when our caregiver issues, or families have to work and can't take care of their parent anymore, can't leave them home alone during the day. These are times when, even during times of COVID-19, it is appropriate to move your loved one to a facility, because the facilities generally are still quite safe. They're not as safe as we'd like them to be. COVID is a pandemic, it's happening every place, but it's still safer than doing it at home. That concludes my presentation. Rob, I'm ready for any questions.
All right. Thank you so very much, Michael. If you will unshare your screen for me, we're going to show you guys another very quick video from one of our sponsors, AmeriGroup, and give you a chance to type in questions over in the chat box. I know that was a lot of information, a lot of fantastic information, but may take you a minute or two just to unpack it in your mind. So give you a chance to take a look at this video, and then we will come right back And when we do, we are going to take a look at this video from Mayor Group, and then we're going to answer your questions.
Stay home. There were many things that happened, but I'll tell you this one. I went in and out of this door 4 times just because I could. It has more motivation someplace than I have ever thought of having.
She sets a goal for herself and she's able to accomplish that.
She's resilient. I got wonderful experiences in my life. I found my passport.
You did.
You're gonna love the picture.
Oh, well.
But I was not right in my heart with myself.
Hey, Rob, we can't see the
I
video.
spent all of my life searching for ways to deal with life. Why do I need food so much to feel okay about life?
All
When we
right.
met her, she was in a nursing facility.
I was very big.
You know, we talked about those fun little moments when the technology doesn't work with us. That's one of them. So I apologize for that. I'll tell you what, we are going to go right into questions. We got a question here, Michael, that is one that we talked about when you have to leave the facility and go to the hospital. What do you do if you're leaving the facility because you tested positive, family member goes to the hospital, and then they can't return to the facility where they came from? What are options in that scenario?
Okay, generally, a facility is not allowed to refuse them to return so long as they're safe. So I'll give you an example though. I had a lady who went in on July 15th into the hospital positive for COVID. She was moved to Hearthstone 5 days later when she was stable and stayed at Hearthstone in their COVID positive wing. She wanted to go to a different facility because at that point they needed to go to memory care. The new memory care wouldn't allow her to come until she had 2 positive tests, but they wanted the positive tests to be within 7 days. So even though she'd had positive or 2 negative tests, and the negative tests had to be within 7 days and move in, even though she'd had 3 different tests that were negative in the previous 2 weeks, they still wanted 2 more tests. That's a little bit extreme, but that happens. Now, if you're in an assisted living, if you go to outside and they're not allowed to refuse you to return for reasons of COVID, so long as you meet their criteria. Now, if they've been trying to kick you out because you're no longer appropriate for their facility, that's sort of a different conversation. Does that make sense?
Yeah. Got another question here. Need to move the parent to a long-term community facility, but the parent has dementia and does not want to move. They will not go. How do you work with the family where it's obvious that there is an issue of safety with the parent staying in the home, but they really, really need to move to a long-term care community, but the parent is just against it completely?
Those are very difficult and heartbreaking cases. Sometimes you just have to wait for the crisis in the sense that they're going to end up in the hospital for one reason or another. That's obviously not the solution any of us want to do. And so a lot of times, well, in the really, really difficult cases, what I've seen is the facility will send somebody on over and they'll just cajole them to getting into the car to go, or try and bully to some degree, or just figure out how to get them over there. The easiest solution, obviously, is when there's a crisis. You don't go back home. You go straight from the hospital or from the skilled nursing home straight to the memory care. So never let a good crisis go to waste in that regard. And otherwise, you almost have to kidnap them in the most extreme cases. That usually doesn't happen, and usually it's better that somebody other than the family is the bad guy, because the family often just cannot do it emotionally. So you have to get the doctor over there and say, no, you've got to go. You may wait until there's a fall and you get the EMS over there and they're helping pick them up and they say, no, we're going to go. You can't go. I mean, if they're holding on to the doors with their fingernails and won't go out, there's not much you can do. You just kind of have to wait until there's an opportunity. You can bring the opportunity to them again by calling the fire department or calling EMS and telling them, hey, you forgot you just fell or something, and cajoling them into going. It's awkward.
Yeah, obviously you want to have those conversations as a family well in advance of having a crisis, but sometimes you don't have that opportunity anymore. I love your idea of using a third party, somebody that they will listen to. A lot of times as the children of the family, you've got that role reversal going on, that you're trying to parent your parent, and a lot of times that doesn't work too well in the mind of your parent. And you can tell them something 5, 6, 7 times, and you know that you're correct, but it takes someone else to just say it once, and they go, okay, yeah. And you're just going, I told you that so many times. But everything from, we need to do your power of attorney and all of these types of things. Oh, I don't want to talk about that kind of stuff, how families are. So finding a third party, a minister, or like you said, the doctor, or even the EMS person who's there, utilizing them on your side, saying, Mom has got to go, tell her we're going to go. So Rona says that that's a great way. Sometimes you just have to take your emotions out of the situation because you have to take care of the safety of your loved one, even if it's something they're going to fight you on. It's just like, taking your child to the doctor. They don't want to go, but they have to go. So I've got a question for you. We talked about the different types of long-term care communities. Can you briefly talk about the costs involved? Because each level offers a different type of service. And so I know that there's a different cost involved to it. Can you hit on that real quick about what's the difference between what it costs to go into assisted living versus memory care, et cetera?
Okay, let's start at the top. Start with skilled nursing. Most of the time people there are, when they're long-term residents, are there in Medicaid. But if you go there in private pay, it generally costs about $180 a night or $5,400 a month for a shared room if you're paying privately in skilled nursing. You can get private rooms as well. Those usually run $7,500 to $12,000, quite frankly, at the nicest places. In memory care, the average price for a private room is going to be about $5,600 a month. In memory care, let me just point out that memory care is usually an all-inclusive price where the care levels are included in the price because you can't do cost accounting on what services are being given to a memory care person, because every hour is a different day. They have good days, they have bad days. You just can't tell what they're going to need. So generally, they're all inclusive. So $5,600 for a private room in memory care, about $4,500 for a shared room in memory care. The cheapest memory care is about $4,200 for a private room and about $3,500 for a shared room in a dedicated memory care, meaning one that has locks on the front door. Of course, there's a lot of memory care or a lot of memory care residents who live in assisted livings as well, and that's a little bit different. Then dropping down to assisted living level, we have to mention that assisted living gives you a base price, and then there's extra costs for level of care. So it's not always apples to apples comparison when you're talking about looking at memory care. Assisted living, a 1-bedroom apartment will generally range anywhere from about $4,200 a month to $5,500 a month. And then the extra levels of care can add another $1,600 on top of that. Mm-hmm. And studio apartments can be a little bit cheaper. The cheapest apartments are generally around $3,000 plus levels of care. And then if we're talking personal care homes, generally a personal care home is going to be $3,500 all inclusive for a shared room, $4,500 all inclusive for a private room. So of course, those prices can go from $3,000 all the way up to $8,000.
And obviously, Medicare is not paying for any of this.
Medicare only pays for up to 100 days a year in a nursing home. There's a medical necessity part of that as well. So usually Medicare will pay for about 3 weeks in a nursing home. But if there's other things, if you have a stroke, they end up paying for more like 5 or 6 weeks because strokes just take longer to come back from. If there's comorbidities, they will pay for up to 100 days per year. And after that, it's all private pay. You have to remember that for Medicare, the first 20 days, there's no copayment. The second 80 days, there's $170 a day copayment on Medicare. Medicaid is the only program that pays for long-term care, and there's 2 criteria for Medicaid. One is financial criteria. Generally, for an individual, you have to have less than $2,250 a month of income and less than $2,000 of assets. The second criteria is there has to be medical necessity. So you can't just check in because you're out of money. You have to check in and be sick enough to stay there. Probably 90% of the time people are in nursing homes on Medicaid, their dementia is involved because people with dementia are a danger to themselves because they can't take their medications properly.
Okay. We had talked about when it's time to move mom, dad, husband, wife into a long-term care community, but because of COVID, we're having a lot of people ask the question, should I move my loved one out of the facility and move them back home? What are your thoughts considering COVID is happening so actively within the long-term care communities, yet is the family ready to have mom, dad, husband, wife come back to their house?
It's an incredibly personal decision. And of course, it all depends on circumstances. As long as they're safe at home, that's the first criteria. The second thing is, though, in a lot of these assisted livings, because people are, isolating in their room, having meals delivered, and they're not doing activities, so it's them in a room with a TV. Yeah, sometimes being at home isn't that much different, and it's cheaper, and there are relatives that you get to visit with. That is not a bad solution. And given my scenario, where it's going to be 8 months or longer before these things are fully open, I would say that's not a bad idea. But it depends on how your house is set up, how your lives are set up, whether or not you can give them an adequate amount of care. And it's going to be an intensely personal decision, but it's not a bad one, depending.
Right. We've got about 10 more minutes, so if you have questions that you want to ask, just type them into the chat box and we will address your question. Michael, I know that every year in the industry you give a presentation about what's coming up in the future. We, for a long time, saw a lot of growth happening in Central Texas with the long-term care communities. It seemed like every other week there was a new one opening on the street corner. They were like Starbucks. There was one in every neighborhood. Because of COVID and because of where the economy is right now, I'm assuming that construction has probably slowed down quite a bit. What are you seeing will be happening in the next year or two in terms of the industry?
We haven't seen the construction slow down that much because when things have already been in process, it's really hard to turn them around. Large assisted living takes about 20 months from groundbreaking to completion. And so the larger assisted livings haven't slowed down at all. The small assisted livings that have been going on, I've seen 1 or 2 that have been pushed off because they can. But once you sort of break ground, you're kind of committed. Now, what we have been seeing is there's been some changes, as the industry evolves. 3 or 4 or 5 years ago, there were a lot of dedicated memory cares that were coming up. So these were buildings with 60 to 90 resident capacities that only did memory care, did not have an assisted living attached. The last 2 years, we've been seeing a lot of integrated communities where we have independent living and assisted living with a memory care wing attached as well, so that there's all 3 types of living options. That's what the current trend has been. Those are larger, more corporate type of places in general.
We had a question that you had earlier talked about the personal homes. And the question is, are those also regulated by the state and are they also licensed?
That's a good question because I didn't touch on that. So in Texas, If you've got 4 or more people living together and paying for help with activities of daily living who are unrelated, you have to be licensed as an assisted living. There are probably over 20 small personal care homes that have only 3 residents, because at that level, you don't have to be regulated. And those places do a very good job for the most part. And those places are important to me because they can do things that a regulated assisted living can't. For example, in theory, well, they can give diabetic shots. Because they're not regulated. They can. I've even had one where I had a ventilator because again they're not regulated. Now, from 4 to 16 beds, you're a small assisted living. So anybody that's got more than so most of these the personal care homes have anywhere between 6 and 10 residents. So they are all licensed. And generally, they're licensed as a Type B facility, which means that they've got sprinklers and fire alarms, and they have to have enough caregivers that they can get everybody out within 13 minutes if there were a fire, for example.
Okay. And as a caregiver, I know that it is very difficult to try to figure out and to siphon through all the information about assisted livings and memory cares, and there are so many of them here in the area. And so utilizing a service like yours is ideal. Can you talk just briefly about your service and how people pay for your service?
Sure, Rob. So my service is free to the client. I get paid a commission, sort of like an apartment hunting service, by whichever assisted living or memory care that you go to. The reason that you use my service is, you'll find that a lot of people, when they say, oh, I need an assisted living, well, I've seen one there's down here in the corner, I'll go there. Well, it may turn out to be that's a memory care and you don't need memory care, you need assisted living, and you don't know that when you walk in. Also, it may be that one is way too expensive. And so they send you someplace else, they give you some referrals, and you go to 4 or 5 places and you choose the one you like the best. Well, there may be places that you didn't see. You may not have considered looking at a personal care home. There may be places that if you drive an extra 20 minutes are 2/3 the cost. And so what my service is, I know every place in town. There are just under 60 memory cares. There's over 50 large assisted livings. There's over 40 small assisted livings. There's 20 unlicensed personal care homes. There's 31 independent living communities. There's 50 skilled nursings. So I've visited every one of these ones personally. What we end up doing is we try and start out looking at your loved one's care needs, at the amount of money that they have, and then geography. And it usually goes by financing, geography, and care needs in that order, surprisingly. I figure that we always want to start as close as we can to family and work our way outwards, because the more often you can visit, the less guilty you're going to feel about the whole situation, and the happier they're going to be, because seeing loved ones is always the best part of their week. And then we try and figure out what the money situation is, the constraints are, and we work our way outward to try and find appropriate places for your loved one. So we're going to be looking at ones where aren't on the beaten track, that you may not have heard of otherwise, and we're going to do we're going to explore whatever makes sense. And this is an exploration. This isn't just a destination. I get to guide people, but I don't make the decision. It's a personal decision the family makes. So looking at the process of looking at 3 or 4 places is also important, because you learn something every place you go. In pre-COVID times, I would put the family in my car and we'd go look at places together. Nowadays, we're doing Zoom calls where we'll have 3 Zoom calls in a row. And by the third time you're on your 3rd Zoom call, not only is your head exploding with so much information, you can't remember everything, but you're starting to realize, okay, this is what's important, this is what's typical, and this is what the differentiators are that make sense. And now that I see how things go, I know Mom would prefer this versus that, and this is sort of the priorities. So my service, I think, is a great one. It is free to the family, and it makes it a lot easier. And the goal is to give the families enough information so they can make the most informed decision possible for their loved one.
Terrific. And I agree. I think your service is fantastic, especially with your expertise in the area. Michael, we want to thank you so much for spending the morning with us and sharing all this information. We know that this is not the ideal time in our lives for having loved ones that need to be in long-term care communities, but at least with this type of information, we can make the best of what we've got, and we can make our best decisions as we move forward. So thank you for sharing all that great information. We want to thank you for joining us on the call today, and want to remind you that tomorrow we're going to wrap up our Williamson County Caregiver Conference, our 7th annual. We're going to have Rob Colgate from the Austin Public Library's Badger Dog Writing Program. We're going to have a really great session about how to use writing in your caregiving journey to help you keep your sanity and to help you be able to move forward with your journey. And always remember that Age of Central Texas, along with Michael Gale at Texas Senior Living Locators, we're all here to help you in your journey. Anytime you need us, give us a call, send us an email, send carrier pigeon, however you need to reach us. Let us help you, because we have the resources, the information, the experts, obviously, to help you to make the best decisions that you can in your journey. And we want to remind you that there is never, ever any shame in asking for help, especially when we are here simply to provide it for you for free. So please take advantage of us. We thank you so much for joining us today. We hope that you'll join us tomorrow, and we will be sending you the link to the YouTube along with Michael's PDFs of his presentation, so you have those that you can look back on them as reference as well. We hope you have a wonderful day, and we'll see you tomorrow.